Manish Kumar, my pleasure. Manish Kumar, my pleasure. Anytime. Array, he's coming. Sarwan, it. What is the indication of reconstructing the medial tibial bone repair? What would you prefer, bone graft or osteotomy? Yes, Hardik Agrawal, good question. There probably will be another talk on Bharati where I have addressed this question, but because you asked, I'll tell you. One thing is that my first aim, like suppose if I've cut the tibia and there is medial defect and the insert I'm using is 8 mm, I would say cut more, use a thicker insert and go to the bottom of the defect. Second thing would be that if your system permits, suppose if your femur is size 4 and then you can use size 1 tibia where you are bypassing the defect, that is best. In a primary situation, I would use a bone graft rather than using a wedge. Now, if the defect is so small that if I use one screw, the graft will break, then I will use a cement in such a case. Means a very small defect, I will use a cement. At least 3.5 mm one screw should go nicely without breaking that graft. That much big defect, if it is there, I will use a bone graft. But don't forget to use a long stem. Whether you use bone graft or screw or cement is immaterial as long as you have taken a purchase into the medullary canal rather than on the surface itself. Now, Pratik Gupta wants to know capsules were single or double. Actually, here, a good question. Closure, we didn't talk this one, a very important question. I use, I don't think about the capsule. What I do is I close quadriceps. I that is as one layer, but I don't use a continuous stitch. I use interrupted stitches, and after taking 3 or 4 stitches, you bend the knee and see the patella is tracking very well. So quartz closure has to be airtight or watertight, as I say. Then I use the subcutaneous tissue interrupted as a fat one layer, and then I use subcuticular and I put some staple. So quartz interrupted, subcutaneous tissue interrupted, uh, subcuticular continuous, and then use a staple. Can you enlighten on cement? See, in the cementing technique, what I normally do is I like to assemble the base plate and the insert outside the body. So I have that as one piece. I use cement, which is generally antibiotic simplex, which has a roughly 15 to 18 hardening, 15 to 18 minute hardening time in my normal OT temperature of 20, 21 degrees. Although they give 18 on the screen where you're working because the lights and all, it is 20, 21 degrees. My working time for that cement is something like 6 to 8 minutes. So what I would suggest is as the cement is mixed, you keep on having a feel by touching it. The minute it stops touching your glove, that is about 4 minutes when that happens, you take the cement. You put it on the tibia, put tibial implant. At that time, tibia should be delivered quite well in front of you with a back lever and a side lever for the patella and right angle for the medial side. Another important thing is push the ankle right back. So when you push the ankle back, the tibia will come forward. And there you put the tibia. By that time, some assistant is putting implant, if you say, putting cement on the femoral implant, and then you put that femur implant onto the bone. So that is how you should do. Between 4 to 8 minutes, your cementing should be over. Then straighten the knee, remove all the cements around, and hold it till it becomes hard. Next is from Dr. Manoj Khimani. When do you deplete tourniquet? In my practice, I use tourniquet for almost all the patients except those who have peripheral vascular disease. That means if the pulse is not palpable or there's any, means changes and all, then I don't use a tourniquet. When I use a tourniquet, I deflate it after complete closure and I use a drain in all the patients. I open my drain immediately and then sometimes I clamp it if they're draining quite a lot. That means 300, 400 ml. If it comes immediately, I clamp the drain. how is high flex joint different from normal implant? See, high flex joint has two important aspects. It allows more flexion. That means it has a slightly more flexion gap. That means the implant, especially the tibial insert, is thinner posteriorly, so they bend more. And also some high flex joint allow loading in flexion. That means in a higher degree of flexion, the post and cam mechanism, that means medial and lateral condyle are the weight bearing structures in extension up to 90 degree. But beyond 90 degree, the medial and lateral condyle are not so much weight bearing, but the weight bearing is done by the post and the cam mechanism. So that is how the high flex implant is different. A, that it has a posterior slope of the tibial insert. B, the post and cam mechanism participates in taking load in higher degrees of flexion. Thank you. More important. Yes. Dr. Haji Garbova, very good question. As soon as you drill the medullary canal, you must put a suction inside and suck it well. Because what happens is that reduces the chances of fat embolism.